Thanks, everyone. We're back at Einstein's Eyes, our YouTube channel. I'm your co-host, Carl Rosen. I'm an oculoplastic surgeon and neuro-ophthalmologist in Anchorage, Alaska. Been here for 3 decades, trained at Albert Einstein College of Medicine in the ophthalmology department in the residency program with my friend and co-host, Jon Ditkoff.
Hello, y'all. So 3 decades, Carl. You look way too young. But Carl and I trained together over 30 years ago at Albert Einstein, hence Einstein's Eyes. I'm a general ophthalmologist, cornea specialist in northern New Jersey, about 20 minutes out of Manhattan. And we just love you coming to our channel and checking it out.
So today's topic, we're going to talk about treating floaters. These are one of the things that happens to everybody. You know, all of us have chased a translucent cobweb or bug, or we thought we saw a cloud in our vision on the periphery or in the center. And it bugs us because it gets in the way of our field of vision. And then all of a sudden it darts away and it's gone. And you're wondering, what the heck is this? Is this a problem? Is this innocuous? So these are called vitreous floaters. And there's a laser procedure out there, which Jon and I are going to talk about, that claims to make many of them vanish. And today we're going to break down the facts and the hype.
Carl, before you get into that, let me just emphasize a couple of things very important for the viewers. So number one, when we're talking about floaters, we're assuming that you've already seen an eye doctor. They've already examined you and made sure your retina is okay and there's no nerve issue or anything serious causing the floater. So now you're left with what we call benign floaters. So that's what we're going to be talking about. So thanks, Carl. Take it away.
Sure. So Jon and I are both ophthalmologists and we're board certified. We've both done fellowships. We're going to decode the eye science so you can see the bigger picture on this. We're basing this on a guy, a doctor, an ophthalmologist named James Johnson, who's got a website. He's in Texas and he practices laser vitreolysis.
But he also does the drops.
He does drops too, and Jon will get into it. Now, as an oculoplastic surgeon and a neuro-ophthalmologist, I never did this. So I fully admit I've never done floater surgery or laser surgery. It's not in my armamentarium. Refer to the retina specialists in Anchorage, and I let them consult with the patient and decide what to do. I'm not a big proponent of it, just to get that out of the way.
And Carl, I would just add, we already have a video about floaters where we had Lee Angeletti, who's one of my retina specialists that I work with, and he is not an advocate of laser. He's an advocate of surgical removal or living with it. Right. But we still wanted to bring up that there are different schools of thought.
Right. So that's the purpose of today's video. So let's start with the basics. The vitreous is a clear gel-like substance that fills the back 2/3 of the eye. We call it the posterior segment of the eye. This is inside the eyeball. And over time, this clear structure that allows light in so that we can see and interpret vision through the optic nerve to the visual cortex. Over time, these collagen strands, they clump up and they cast shadows on the retina. And then we perceive these as floaters. They often form something called a posterior vitreous detachment. And this can happen more in some people who are nearsighted, called myopia. The longer the eye, the more likely that you'll get floaters because the attachments get weaker because the eye is longer. If you get hit in the eye, you fall, you have an accident, that can also trigger floaters. While most of these are benign, some floaters can be visually and emotionally significant and disruptive, especially large or centrally located floaters that don't settle out of your visual axis or your visual line of sight. And that's the ones we're talking about today. Here's an image of floaters in the eye that can get in the way. This is the optic nerve back here. This is the retina. Here's the optic nerve up in the front, and this is called the anterior segment. Where the gel is and the floaters are is called the posterior segment. Right here is the lens. This becomes a cataract. You place a device, a contact lens, and then you do a laser through this that focuses and lasers the gel that's clumped or the floater. This is what we are talking about. There's three tiers of conventional management. One is watch and wait. We just reassure patients, we monitor, we say the floaters may fade, or patients can something called neuro-adapt. They just get used to it. They don't see it anymore. It just doesn't bug them. It's like you live in your neighborhood and you don't see the trees in your neighborhood or your neighbor's mailbox. It just kind of fades out of vision. The second thing is this thing called YAG-laser vitreolysis. And that's where you use low energy nanosecond pulses that convert the floater collagen clump into gas microbubbles that the eye reabsorbs within hours. The last thing is floater-only vitrectomy. Now, a vitrectomy is where you create incisions into the eye, you put these probes in, a port, a light pipe. It's real surgery. You have to put the patient to sleep oftentimes, not always, but many times. And you go to an operating room and you remove the vitreous jelly and you replace it with saline. This is highly effective, but like I said, it involves incisions, anesthesia, and it does have higher complication rates, including retinal detachment and cataract formation, which then requires another surgery.
I'll hit each one as Carl did. Number one, that's what most people do. We watch and wait. And as Carl mentioned, they learn, the brain and the eye are amazing at learning to tune it out, just like learning to tune out your annoying neighbor or some sounds. You live down the block from the train station. You don't notice those things. So that's what happens for most people. Second treatment, I agree, the laser is an option. Some doctors are proponents. Some of my patients have had it done and they swear by it. The problem I have with the laser is there's really new great studies that I'm aware of that show that it really does work. And one of the problems is if I did a laser on you tomorrow because you had a floater that annoyed you and I said, I think in 6 months this is going to work, there's a good chance without the laser it's going to work. So I have a hard time buying it completely because sometimes nothing, as I mentioned, just doing nothing at all will work because the person learns to tune it out. And then there's 3, which is the vitrectomy. We have a video on it. You can watch Dr. Angeletti talk about it. He really feels in his hands there's a very high success rate. I mean, 98, 99%, and especially if someone's already had cataract surgery. So he's a big proponent. It's a 10-minute procedure. He does it quite often on many of my patients, and they're very happy. But I think Carl's right. I've had one patient who had a complication, so it can happen, and that's serious stuff. So you really have to weigh how bothered you are. And then there's this exciting new treatment that I was not aware of. And that's part of the reason we did this video, which is Dr. Johnson. I did a literature search. I did a search on the web, and he is a proponent of dilating drops. So the concept is very simple. And we know this as eye doctors. Many of my patients that come to my office, they come with floaters that are new, that they're very bothered by. We dilate their eyes so we can check their retina. And by the time I come in to see them, they say, ever since you put that drop in, I don't see the floater. And what we've learned is when you dilate someone's eye and you change their focus, just like that picture that Carl showed, they're not able to see the floater as well. So Dr. Johnson is a proponent of this relatively novel new approach where what he does is, and he doesn't need to be the one that does this. Anyone can do this. That is a special pharmacy that does the mixing. So they take atropine drops, which is a dilating eye drop that's extremely strong. So if you put 1 drop of atropine full strength in your eye, your pupil will be fully dilated. Some people will claim 3 weeks. So we don't do that to people unless there's a reason. What he's a proponent of is taking atropine and diluting it out tremendously to a very, very dilute out amount of the medication. So it causes some dilation, but not all that strong. And his patients are using it. He basically, what he claims is by putting the drop in once a day, twice a day, whatever you need, where the float is bothering you, the patients are noticing the floater less. And it's very simple. It's making their focus a little bit different by dilating the pupil. Now, is there a downside? Sure. If you dilate someone's eye and they go out on a sunny day, which we get in New Jersey, not so much in Alaska, but if you dilate someone's eye, that lets more light in. So all of a sudden you have to put on sunglasses, or you're more light sensitive, or even potentially you're letting more UV light get into your eye that could damage your retina, could damage the lens of your eye. Then there's the second part, which is it might make your focus enough out of focus that you don't like it, but you can always try that. And then there's a very, very rare complication of dilating drops, which realistically with a dilute drop is probably very unlikely, but not zero, where you could actually cause a retinal tear or retinal detachment. So you have to weigh those risks against the benefit. And, we're all learning about this. I mean, I actually had my first patient go on this treatment about a week ago. So if you guys want to know what happened with it, just reach out to me and I'll let you know how we went with him.
To go over the risks and complications again from this procedure: higher pressure in the eye, inflammation, pitting of the lens or cataract formation, retinal detachment, or retinal tear. There was a review called the Cochrane Review back in 2017, studied head-to-head trials comparing vitreolysis with vitrectomy, where one is the laser, the vitreolysis, versus vitrectomy, where you go to the operating room. And it really found insufficient results comparing, saying one is better than the other.
Okay, I didn't know that. That's helpful.
Yeah, so that was done in 2017. I mean, we certainly could use an up-to-date study. So what are the pearls for us? You need to do a detailed exam. You need to find the right patient who's really complaining, who understands the risks and benefits and has proper expectations. Imaging needs to be done either with an ultra-wide field contact lens, a dilated exam, looking at the retina, make sure that it is indeed what we think it is, that it is a floater. OCT or optical coherence tomography, which most ophthalmologists have in their office, can also help determine that, as well as something called ultrasound or B-scan. Counseling with a retinal specialist who does vitrectomy and laser vitreolysis. You need the experience. You need to talk to someone who's doing this a lot. I'm not going to go out and tell my patients, yeah, go ahead and do this. John, anything else?
No, that was great. Great job, Carl.
Yeah, so thanks, everyone. Please like and subscribe, and thanks for showing up, guys. Bye.
Enjoy.